There are lots of definitions that we're going to go over in this lecture, and they include like the cardiac, all the definitions for the cardiac cycle, and then definitions for cardiac output. And so get ready for it. So what is a cardiac cycle? It's everything that happens in one heartbeat. I'm saying everything here and here right now. It's everything that happens in one heartbeat. As blood flows into the atria, then it passively flows down into the ventricles. At that point, the atria and the ventricles are in diastole. Diastole means relaxation. But pressure starts building up in the ventricles, and then the atria will go into systole and contract the last unit of blood down into the ventricles. And then the ventricles will be ready at that point to go into systole, and they will contract. So that's everything that happens in one heartbeat. And if your heartbeat is around 75 beats per minute, notice that each heartbeat lasts less than a second. The atria relaxing and contracting, the ventricles relaxing and contracting. There are two terms that are interesting: isovolumetric contraction phase. In this phase right here, this is this picture up here. Notice here we have our tricuspid valve. Here we have our pulmonary valve, our aortic valve, and our mitral valve over here. Notice that they're all closed and there is increased pressure in these ventricles. This is the isovolumetric contraction phase, when all of your SL and AV valves are closed, but the ventricles are they're trying to contract, and they're trying to increase pressure enough to eject blood up into the pulmonary trunk and up into the aorta. Now, but there's a very split second in time where the pressure is building, but it's not enough to move that unit of blood to open up this pulmonary valve, open up this aortic valve, and move the unit of blood through and the whatever blood that's in here on its way. So for a split second in time, we have a lot of pressure in the ventricles. And think of it this way, like if you're about to run, you get down in a running stance. Think of that as the isovolumetric phase. You're about to spring off and take off. This is a point right before the ventricles can actually eject the blood up into those great vessels. In the isovolumetric relaxation phase, this is going to come after the isovolumetric contraction phase. And in this, pressure is down. So this is this picture up here. We've got pressure down in the ventricles, but for just a small moment in time, all of these are closed. All of your SL valves, of course, are going to be closed in this phase, but it's strange to have, after the ventricles have contracted, to have the AV valves closed, but they're still closed. So blood starts coming into the atria, and I always say blood comes into the atria and passively flows down into the ventricle. But you have to get enough of that blood flowing down into the atria to open up those AV valves to let it passively flow into the ventricles. So at this point in the isovolumetric relaxation phase, blood is not moving anywhere in the ventricles. Same here, isovolume, this means same measurement. We're talking about the ventricles. Blood's not going anywhere in the ventricles yet, and the pressure is down in this. And we're waiting for the AV valves to open because pressure is greater in the atria than the ventricles. But at both of these, at this point right here, we're in ventricular contraction. We're in ventricular systole, V-systole. Here in this isovolumetric relaxation phase, we're in complete atrial and ventricular diastole. Everybody is relaxed for just a moment. Okay, moving on to our next definition, because this seems to be a lecture of definitions, the quiescent period. There is a time of total heart relaxation before the atria are going to contract and send the blood down into the ventricles before the ventricles contract. That is called the quiescent period. We've already done our heart sounds. Now we're moving on to cardiac output. Cardiac output is an incredibly important topic because it's the amount of blood that's pumped out of each ventricle in 1 minute. Know this definition: the amount of blood pumped out of a ventricle in 1 minute. And we know we have a left ventricle and a right ventricle. For the most part, I'll be talking about the left ventricle. but we also have a right ventricle. And if the left ventricle pumps 4 liters of blood per minute, then the right ventricle must also pump 4 liters of blood per minute. They have to pump equal volumes. So what is this definition? Cardiac output, CO stands for cardiac output, SV stands for stroke volume, HR stands for heart rate. So we're going to use these standard numbers down here so I don't have to think about math. If we have stroke, here's cardiac output. We want to figure out what our cardiac output is. Stroke volume is that left ventricle contracts and it ejects blood into the aorta. How much blood is actually now in the aorta, sent up into the aorta? It's the volume of blood being pumped out of each ventricle during systole. So it's what's leaving the heart. So if the normal stroke volume is 70 milliliters per beat, let's do this up here. 70 milliliters per beat is pumped out. I've just put, here's our stroke volume number, and we have 75 beats per minute. You know from math that we can cancel out these beats to get the units of milliliters on the top, minutes on the bottom. So if we multiply these out, we're going to get an answer of 5,250, hopefully, milliliters per minute. But we don't usually talk about massive amounts of milliliters like that, of volume of blood like that in milliliters, so we have to convert this to liters. So because there are 1,000 milliliters in each liter, then we can divide this number by 1,000 and we get 5.25. A person with a heart rate of 75 beats per minute and a stroke volume of 70 milliliters per beat will have a cardiac output of 5.2 liters per minute. That's more than 2 liters, right, of Coke or whatever. That's a lot of blood cardiac output, but that's a normal cardiac output. So notice this is a direct relationship. If we increase stroke volume, we increase cardiac output. If we increase heart rate, we increase cardiac output. And so we have to kind of look at these individually, by the way, because there are going to be some reasons where if we increase heart rate too much, we're actually going to reduce cardiac volume. So we do need to pay attention to that. Let's see. Let's make this cardiac output, just so you remember that this is a direct relationship. If stroke volume is 1 and heart rate is 1, what is cardiac output? 1. If we increase heart rate, let's just make heart rate 2. What happens? Cardiac output goes up. If we increase stroke volume, let's say stroke volume's 3, these are nonsensical units, but you get the point. It's a direct relationship. Either of these increase, then this is going to increase. But there's going to be limitations on that, and that's what we're about to get into. Now, the term cardiac reserve is that difference between our resting cardiac output. If I'm sitting here and I'm pumping 5.25 liters of blood through my left ventricle and my right ventricle, both of them, per minute, then my cardiac reserve would be the difference between that number and my maximal cardiac output. So if I decided to go outside and run as fast as I could down the road for as long as I could, I would definitely reach my maximal cardiac output, and it would not be that of an athlete. My cardiac reserve would not be that of an athlete because I'm not athletic anymore. But with athletes, they have a higher cardiac reserve. The difference between their resting cardiac output and their maximal cardiac output is much higher. And that's a good sign of a healthy heart. Okay, I know this looks boring with the definitions, but notice that cardiac output is stroke volume times heart rate. Well, now we have a definition for stroke volume. Stroke volume is the amount of blood that leaves the heart per contraction. This leaves the ventricle, and it's going to go up. I'm going to only talk about the left ventricle. It's going to go up into the aorta. That's the amount that's ejected into the aorta. Well, this actually has its own equation. It's N diastolic volume minus N systolic volume. So what this means is at the end of ventricular diastole, what is the volume of blood in the ventricle? So I'm going to draw this on another page. You'll be impressed with my art skills. But basically, your left ventricle is sitting there, it's filling up with blood, and then it's in diastole, it's relaxing. When it contracts, then it's going to shoot blood out, and that is stroke volume. The left ventricle or the right ventricle, if this is the normal and diastolic volume, at the end of diastole, when the ventricle is relaxing, we have 120 milliliters of blood in it. If we contract and send 70 milliliters out, we got that from the last slide, our normal stroke volume is going to be 75 milliliters per beat. If 70 milliliters leaves, 70 milliliters leaves, how much is left behind? About 50 milliliters, right? 120 minus 70 gives you 50 milliliters, meaning at the end of systole, there's still some blood down in that left ventricle. Here, there's more blood before it contracts. We lose blood to stroke volume going out into the aorta, and some blood is left behind. So please know this definition, because understanding stroke volume, to understand stroke volume, you have to understand what is going to affect my end diastolic volume and what is going to affect my end systolic volume. Like, if this number goes up, what does it do to this number? If this number goes down, what does it do to this number? So knowing this equation will help you out greatly, because then you can break stroke volume down into individual effectors. So end diastolic volume, what is it affected by? You're pouring blood into the heart. We're going to have these two things, venous return, we're just going to call this exercise right now, and the muscular pump. Muscular pump. When we return blood to the heart, it's easy to return blood back to the heart through the venous system if our muscles contract. Think of it as actually squeezing blood back up to the heart. That's what venous return is. And if you're exercising, you're going to be returning blood to that right atrium faster. So now I say we're going to talk about just the left ventricle, but in this case, if we're exercising, we're sending blood back to that right atrium at a much faster pace. Now, heart rate is also going to affect end diastolic volume. On my next slide, I have a blank page where I can draw this. So remember venous return and heart rate. I'll go ahead and do it. In end diastolic volume, say we have our right ventricle, because remember that blood returns from systemic circulation to the right side of the heart. And I'm not drawing the atrium here because I'm not a good artist, but if we take blood and we put it in here faster, if we pour it in there faster because of increased venous return, then it's going to fill up. It does not say venous. If I misspelled that, it's just because I'm too close to the screen. Increased venous return. If the faster the blood comes, the faster it fills up. So if we have the ventricle contracting every second, just say it's contracting 1 time per second. If blood's flowing in, and we have 1 second to fill this guy up, if blood comes in slow, and if blood comes in fast, this is normal venous return. If we increase our venous return, then the blood is going to fill up more. You're going to have more opportunity for more blood to fill in. Increased venous return allows more blood to come back to the left ventricle or to the right. I should just quit. I should just quit today. But increased venous return returns blood to the heart and faster, much faster. That is going to increase in diastolic volume, because if we only have 1 second to fill this ventricle and the blood's coming in slowly, or 1 second to fill this ventricle and the blood's coming in fast, we're going to get a higher volume at the end of diastole. So increased venous return increases in diastolic volume, increases the volume of blood in the ventricle at the end of diastole. The second thing that increases in diastolic volume is what if we decrease the heart rate? If we decrease the heart rate, say the heart rate is 75 beats per minute. I shouldn't do that way, beats per minute, or the heart rate is 60 beats per minute. We're pouring blood in here at the same pace. Ignore venous return now. We're pouring blood into this ventricle that's going to beat 75 times per minute, and we're pouring blood into this ventricle that's going to only beat 60 beats per minute, and we're pouring at an equal rate. If we do this, if we decrease heart rate, this is our normal heart rate, blood fills up, and then the ventricle is at the end of diastole, it's about to contract. If the heart rate is slower, we have more time to pour that same rate of blood in, and we'll have a higher end diastolic volume because the ventricle has more time to fill. Sort of like if you put your cup underneath a sink and you let it stay there for a while, it's going to fill up with the volume, right? But if you put your cup in and pull it out really fast, we're going to have a smaller volume of blood, of water in the cup. So these two things, increasing venous return will increase in diastolic volume. How does that affect stroke, cardiac output? So cardiac output is stroke volume times heart rate. Now we're pretending like our heart rate isn't changing here, even though we know when we exercise, our heart rate goes up. But if we just look at one thing at a time, if we increase venous return, we have to do our stroke volume equals end diastolic volume end systolic volume. Okay, if we increase our, if we want to increase our stroke volume by increasing venous return, this is how it's going to work. If we pour blood faster into the ventricle, instead of the number being 120 milliliters, let's assume we can get 130 milliliters in here. So this is without increasing, me too. Can't erase this. That's unfortunate the way I've started drawing this. The stroke volume, we're going to keep our end systolic volume the same, which is going to be 50 milliliters. A normal stroke volume is 70 milliliters per beat. But if we increase our end diastolic volume, I'm just increasing it by 10 milliliters, and we keep that normal, ignore the drawing, end systolic volume, then now we're pumping out 130 minus 50 gives us 80 milliliters per beat. So by increasing venous return, we're increasing stroke volume. Now, stroke volume before was 70 milliliters per beat, and our heart rate was 75 beats per minute. If we increase this number, like I said before, 80 milliliters per beat, even though we're just going to keep this constant, 75 beats per minute, which is illogical if you are exercising. But I think you get the point. If you increase in diastolic volume, which is what we're doing here, then you're going to increase stroke volume. That's a direct relationship if you increase in diastolic volume. And we can increase in diastolic volume two ways. We can increase it by venous return or by heart rate, decreasing heart rate, giving the ventricle more time to fill. If you know these equations and you're asked a question on a test about these, you can sit down and work your way through it. If you memorize the fact that increasing venous return or decreasing heart rate increases in diastolic volume, that's not information that's going to be usable. You have to know the formulas to be able to reason through each various scenario. So, heart rate, we can put lower heart rate increases in diastolic volume. So the opposite is going to be of high heart rate. A low heart rate maybe let's do the term bradycardia, means a low heart rate. That would increase your end diastolic volume. If someone has tachycardia and their heart rate goes up, just sitting around over 100 beats per minute, how is that going to affect end diastolic volume? Well, if the heart is just contracting like this, the ventricle, it has more time to fill before it contracts and sends the blood out. But if the heart rate gets too fast and it's like this, it doesn't, the ventricle is just pumping along, it doesn't have time to fill. And so tachycardia, a really high heart rate, can reduce cardiac output because it's reducing end diastolic volume. And if you reduce end diastolic volume, what does that do to stroke volume? Plug some numbers in there and see. And I would just use ones and twos, etc. Okay. In systolic volume is affected the end of systole. Here is the ventricle, it fills up with blood, it contracts, it sends a stroke volume out. Now the volume of blood that's left behind is, in our math, we're using 50 milliliters that's left behind. So what in systolic volume is really going to be affected by are two different things. First of all, the easier one is how forceful the ventricle contracts. So if I have blood in me and I'm a ventricle and I just contract like this, I send out 50 milliliters. If I really forcefully contract, which I can't really show you that with my hands, if I have a very forceful contraction, I can squeeze more blood out. This forceful ventricular contraction will go into what causes that here in a little bit. But afterload, what I want you to think of afterload is the blood pressure inside whichever artery that the ventricle is sending blood into. If we're the right ventricle, we're sending it into the pulmonary trunk. If we're the left ventricle, we're sending it into the aorta. So let's get into this afterload situation. I'm going to clear this and get back to it. End systolic volume. Here was the ventricle at the end of diastole, and it had 120 milliliters in it, and it contracted, and now we have 50 milliliters in it. That is end systolic volume. What unit is left? It would be stroke volume at 70 milliliters. So stroke volume leaves, and the difference but 120 minus 70 milliliters gives us 50. At the end of systole, we have 50 milliliters. What if that ventricle contracts much more forcefully, and instead of sending 70 milliliters out, it sends 80 milliliters out because it has a much more forceful contraction? How is that going to affect end systolic volume? Well, if you do the math, if your end diastolic volume, stroke volume, equals end diastolic volume minus end systolic volume, and what we're going to find is stroke volume, we've increased it to 80 milliliters. And our end diastolic volume, we're keeping the same. So what does that do to our end systolic volume? 120 minus 80 gives us 40 milliliters. So increasing the contractility, or how hard the ventricle is contracting, will reduce end systolic volume. Reduces end systolic volume. This goes down. It was 40, now it's 50. But that might seem obvious to you. The ventricle contracts more forcefully. What's left behind? Less blood. Okay, now when it comes to afterload, though, this afterload concept is super important to understand on how our blood pressure affects our heart health. And this is where I definitely will focus just on the left ventricle. Afterload is the amount of pressure the ventricle, and I'm going to put the left ventricle, has to overcome to eject blood into the aorta. Whoops. Now remember, at the base of the aorta, here's the base of the aorta, we have the aortic semilunar valve, which is tricuspid, but you can only see two cusp in this view. I'm going to draw just the left ventricle. Now we know the left ventricle is attached to the left atrium, but I can't draw that, so just deal with it. So at the end of diastole, we have 120 milliliters of blood in here. At the end, this is our end diastolic volume. And we want to eject blood up here through this aortic semilunar valve into the aorta, into the rest of the body. Well, it's not as easy as this because really what we should be drawing, here's our ventricle down here with 120 milliliters of blood in it. It's our end diastolic volume. There's a unit of blood in here pressing against the walls of the aorta and those semilunar valves. And so that's always in there because if you're contracting and you're sending blood up, not 100% will go up and over that aortic arch into the body. So it's going to come back down and it's going to close those semilunar valves. So there's a pressure inside the aorta. Here we're looking at diastole. At the end of diastole, or during ventricular diastole, it doesn't have to be even at the end. What is the pressure that the aorta is experiencing? Oh, it takes forever to draw on here. Okay. So we're at rest. Our ventricle's at rest. We're not doing anything. But there is blood up in the aorta and it's pressing on the walls. How much pressure is that? We can measure it. When you take someone's blood pressure, you're measuring two types of blood pressure. You're measuring the amount of blood pressure that's in the aorta when the left ventricle is relaxing, and that is diastolic blood pressure. Get up here. Say your blood pressure is 120 millimeters mercury. I'm having a hard time today. 120 millimeters mercury. That's the pressure. You went to the doctor and they measured 120 millimeters mercury over 80. This is your diastolic blood pressure. This is your systolic blood pressure. Really what you can think of is, even though you're measuring blood pressure maybe in the brachial artery or somewhere else in the body, what you can think of is this diastolic pressure, the one that's on the bottom. This is the pressure that the aorta experiences during left ventricular diastole. It's got blood in it, there's pressure in it. Not as much pressure as when this ventricle contracts. When the ventricle contracts, it has to contract with enough force to eject this blood, right here, up, open these valves, send this unit of blood on, and send this unit of blood up here. So think of this diastolic pressure as a back pressure against this aortic semilunar valve. When the ventricle contracts, forces the blood up into the aorta, it slams into the aorta wall, and that is our systolic blood pressure. This is the pressure. Systolic blood pressure is the pressure that the aorta experiences during left ventricular systole. So, what is the importance of this for stroke volume? Well, stroke volume is the difference between end diastolic volume and end systolic volume. This, by the way, afterload, now we know, is this. It's the pressure that the left ventricle has to overcome to get blood up into the aorta. And that is also this right here. So if we increase afterload, meaning say you go to the doctor and they check your blood pressure and it's 120 over 90, that's a higher amount of pressure that the left ventricle has to overcome to get blood up into the aorta. This afterload has increased. So the more pressure we have, if that ventricle contracts and sends blood up, it's not going to get as much blood out into the aorta as it normally would. And so if we keep our end systolic volume like this, and our end systolic volume, what we're looking for here, afterload is going to affect end systolic volume. If we've got too much pressure coming down here and the left ventricle contracts, it can't send as much blood up. So let's take our stroke volume and reduce it. The normal volume we've been using is 70. We can't get as much blood out. So what does that do to the end systolic volume? Well, 120 minus 60 is 60. In our normal equation that we've been using, it'd be 50 milliliters. So just know that the higher this number is, this diastolic pressure, the harder the left ventricle has to contract to send the same amount of blood to maintain cardiac output. Because if the left ventricle doesn't contract more forcefully, it's going to eject less blood, meaning the stroke volume will be affected. It'll be reduced. That means cardiac output will be reduced, and end systolic volume will be increased. This is stuff you have to play around with. And in class, I give you a worksheet that I really want you to do because I think it will help you to understand how afterload affects all of this. It's overwhelming, but really, if you just know the equations and what the equations stand for, like end diastolic volume and end systolic volume, you can work through all of this. Okay, so when it comes to stroke volume, we know stroke volume's affected by end diastolic volume and end systolic volume, but we can word this differently, and we can say that three main things that affect how much blood leaves the ventricle during contraction would be preload, contractility, and afterload. Afterload we just described, that's that diastolic blood pressure. It's the amount of pressure that ventricle has to overcome to send blood up into the aorta. So afterload affects end systolic volume. If you increase afterload, as we just found out, if you increase that pressure, we are going to increase end systolic volume, and that will reduce stroke volume because we're sending less blood out. And our original equation, maybe not in order, cardiac output equals heart rate and stroke volume. If we reduce stroke volume, this directly relates to this, so we reduce cardiac output. On the side of contractility, we haven't really talked about that. We have talked about preload. Preload is the amount of blood we put into those ventricles right before they're going to contract. And so if you increase preload, think of venous return as being preload. If you put more blood, this is showing you preload down here. If you put more blood in here, these ventricles are relaxed. The more blood that returns to them, the higher the preload. It's going to affect your end diastolic volume. You're going to increase, if you increase preload, venous return, you increase end diastolic volume. If you increase end diastolic volume, what is that going to do to stroke volume? Well, it depends. It's really going to increase it, but I'll show you why down here. It helps with stroke volume. On contractility, this is the one thing that we've not discussed. Contractility is literally how hard your heart is contracting. The more forceful. This has to do with force of contraction. Now, preload, you can think of it as you're sending blood in, it stretches the ventricles, and you get a little more bang for your buck when they're stretched more. So like a rubber band, if you're stretching a rubber band, the more you stretch it, you let it go, the more the farther the rubber band can go. So with preload, stroke volume increases because you've stretched the heart, basically. In contractility, that's different. If you've ever felt your heart beat out of your chest, that's contractility. That is the force of contraction, and that is not the same thing as preload. This is usually done by medications or by hormones like epinephrine if you're in fight or flight. Let's talk about this Frank Starling law of the heart. If it says that stroke volume is going to increase if you increase venous return. And venous return is increased by exercise or slowing down your heart rate. We've already gone over this, but think of it, like I said, you stretch the heart, you get more bang for your buck on the money, that's on the bang for the buck on the blood that's going to be ejected into the aorta. Now here we're getting into contractility, how strong the heart actually contracts. It is independent of muscle stretch. Muscle stretch is preload. That Frank Starling law of the heart, independent, has nothing to do with that. It's increased by extrinsic factors, like say we have, usually we are increasing calcium, and we're increasing calcium inside the muscle cell itself. Don't think of the actual cardiomyocyte, that graph that we did last time. Go back to the muscle chapter and think about how calcium helps with muscle contraction. It is that final trigger for muscle contraction because it can move, it can change the shape of troponin, move tropomyosin off those binding sites, etc. So if we increase calcium by extrinsic factors, we're going to have a stronger contraction. And if we have a stronger contraction, that's going to lower our end systolic volume because more blood will be injected during stroke volume. And this stronger contraction is always going to be due to higher amounts of calcium inside the cell. So what can cause higher amounts of calcium inside the cell? Things called positive inotropic agents. These increase calcium inside of the muscle cell. Examples would be like glucagon. Glucagon actually acts as a positive inotropic agent. When we were in the endocrine chapter, if you remember, glucagon, what it does is it increases blood glucose levels by going to the liver and telling the liver to actually break down, the sun's coming out, telling the liver to break down glycogen to release glucose. But it also increases the calcium availability to the heart. So if they give you glucagon therapeutically, it can increase that contractility of the heart. Also, thyroxine. If people wonder how are high levels of thyroid hormone affecting the heart? Well, they increase the contractility and they increase cardiac output. And the reason they do that is they increase calcium availability to cells. And you all know, if you've been scared out of your wits before, if you have excess epinephrine, all of these are going to be working by second messenger systems. And the second messenger systems, these hormones are going to dock on the outside of the cell and cause the release of more calcium from the sarcoplasmic reticulum inside the cell. If you're a negative inotropic agent, that means you're going to reduce the amount of calcium available to those cardiac myocytes. That means you're going to reduce contraction. So some people are put, one example, there are certain ions that count as negative inotropic ion agents. We're just going to focus on calcium channel blockers. Some people are put on calcium channel blockers because if they are, as the name suggests, it blocks calcium channels. And so it reduces the amount of calcium available to the muscle cells. So it will reduce contractility. Wow, this just keeps going, doesn't it? We've already gone over this, though. This afterload is the amount of pressure that the ventricles have to overcome to get blood into the aorta. But the only new bit of information on this slide would be the fact that if your diastolic blood pressure is 80 millimeters mercury, that's your diastolic blood pressure, right? That is the afterload that the left ventricle has to overcome. In the pulmonary trunk, the blood pressure is much lower. The pulmonary trunk, the right side of the heart, sends blood to the lungs, which are just adjacent to the heart, right? It's a low pressure system. So we don't need to just, the aorta high pressure because we're sending it out to the entire body. So this is the amount of pressure in the pulmonary trunk that the right ventricle has to overcome. This is the amount of pressure, 80, that the left ventricle has to overcome. So if you have that higher blood pressure, afterload lowers stroke volume by increasing the amount of end-systolic volume left behind. It's a lot. You need a worksheet to practice this stuff. This is comparing and contrasting preload. Preload is how much you're loading up the ventricles before they contract. And the stretch helps, but it does not increase contractility. Afterload is the amount of back pressure up here that when these ventricles, here's the left ventricle, here's the right ventricle, when they contract, they have to be able to move whatever blood's in here up and forward and move this unit of blood up here and open these pulmonary similar valves. Or this guy contracts, notice how thick the wall is in the left ventricle. It has to overcome more pressure because maybe this is 80 millimeters mercury in here. Maybe this person has 8 millimeters mercury of pressure in the pulmonary trunk. Okay. This will help you. It really will. Right now, you don't want to look at it. You want to be in denial. You want to put it in your denial pile. But I'm telling you, if someone says, what are the factors that affect cardiac output? One, exercise does. How? We'll describe that in a second. Heart rate affects cardiac output. How? We'll describe it in a second. Hormones, epinephrine, thyroxine, or if we have excess calcium, which is obviously not a hormone, that can affect cardiac output. And exercise, fight or flight, anxiety, how does that affect cardiac output? This is how we're going to read this. It's important that you just draw this, just memorize it, do it. If you increase exercise, remember you're increasing venous return, the amount of blood that's going back to the heart. And if you increase venous return, then you're increasing preload. So that preload is the amount of blood in the ventricle at the end of diastole. If you do the math with all the equations, if you increase preload, then you're going to increase stroke volume. And cardiac output, if you increase stroke volume, you increase cardiac output. So this is how we read this. What if we drop our heart rate? Well, if we drop our heart rate, and you can flip these back and forth all you want. You just have to be able to reason through it. If you decrease your heart rate, well, you're going to have an increased venous return, only because, not because the blood's coming back to the heart faster, but more so because of the preload. You have more time for ventricular filling. If you have more time for ventricular filling, that increases preload, which increases stroke volume, increases cardiac output. So either increasing exercise or decreasing heart rate is going to increase stroke volume and therefore increase cardiac output. If you have hormones like thyroxine or epinephrine, we should put glucagon on here since it was on the last slide, then what that's going to do is it allows more calcium to be available to the heart cells so they actually contract harder. Well, if you contract harder, you send more blood out. That increases stroke volume right away because you're sending more blood out. But it's reducing end-systolic volume because remember, stroke volume is affected by these two. So increasing contractility reduces end-systolic volume, which increases stroke volume, or you can think of this as the cart before the horse. I don't care how you do it, but this is something you need to know. Stroke volume increases cardiac output. And if we go over here with exercise, if we increase exercise, we already know over here, if we increase exercise, it's going to increase venous return, aka preload. That increases stroke volume and cardiac output. But in this case right here, what we want to think of is how exercise and fright will increase sympathetic activity. And by the way, if we increase sympathetic activity, we can draw a line straight here, which I should have. Sympathetic activity, because of the release of epinephrine, increases contractility, reduces end-systolic, increases stroke volume, and increases cardiac output. But also, besides increasing, so draw yourself a little line in there because that needs to go this way. It's an arrow I forgot. I'll go back and fix the slide. But this sympathetic activity increases heart rate. You know, if something scares you, your heart rate jumps up. And that's because we have increased sympathetic activity. And if you're exercising, you're going to have increased heart rate. Well, increased heart rate increases cardiac output. So if we increase heart rate, we increase cardiac output. Now, we have dual innervation of the heart. We have the autorhythmic cells, the cardiac conduction system. I'm drawing the SA node. I'm drawing the AV node, the bundle of His, the bundle branches, Purkinje fibers going up here. That's the electricity, right? But those autorhythmic cells of the heart. But we also have innervation by the parasympathetic fibers and the sympathetic fibers of the autonomic nervous system. And that's really important to know, because if the parasympathetic nervous system is in control, your heart rate is lower. If the sympathetic nervous system is in control, your heart rate goes up. So they never are sending equal signals at the same time. They're competing. It's dual innervation. So if sympathetic activity goes up, we know that parasympathetic activity has gone down. And that is hopefully the end of this lecture. Let's see, is it? We might as well keep on going. No, let's save this to the next lecture. You can do this. You just need to play around with the math. Come on.